Welcome to Studious. Today, we're diving into a complete clinical atlas of the female body surface, mapping every visible and palpable structure that doctors use daily to examine, diagnose, and treat patients. This isn't just a beauty tour of the body. This is clinical intelligence. Surface anatomy is one of the first and most powerful tools a clinician reaches for because the body's exterior tells an incredibly detailed story about what lies beneath. In this video, we'll walk through 13 illustrated slides covering everything from the shoulder girdle to the heel, including bony landmarks shown in orange-red, soft tissue in teal, and clinical hotspots in gold. Each structure has a name, a feel, and a purpose. Whether you're a first-year medical student, a nursing student, or just deeply curious about human anatomy, this atlas will change how you see the body. Let's begin.
Before we look at specific body regions, we need to understand the 3 types of surface features a clinician interprets during any physical exam. First, bony landmarks. These are rigid, hard, unyielding projections of the underlying skeleton. When you press on them, they don't give way. They serve as fixed structural reference points that never shift, making them the gold standard for orientation. Second, soft tissue. Muscles, fat pads, and skin folds that feel fleshy, yielding, and dynamic under the fingers. These help assess musculature and give context to structural mass. Third, external organs and scars. Functional surface structures like the umbilicus or reproductive structures, with variable palpation field depending on context. Together, these 3 categories form what we call the diagnostic matrix, used across auscultation, inspection, palpation, percussion, and function testing to build a complete clinical picture.
Let's begin at the top of the torso, the shoulder girdle. The first landmark is the clavicle, commonly known as the collarbone. It's an elongated S-shaped bone resting horizontally across the top of the ribcage, connecting the sternum to the shoulder. It's easily palpable. Just run your finger along the top of the chest, and you'll feel it clearly. Next is the suprasternal notch, also called the jugular notch, the visible U-shaped depression at the base of the throat, marking the superior concave border of the manubrium. This is a key midline reference used during intubation and thyroid assessment. Then we have the trapezius, a flat, triangular muscle of the posterior shoulder blade, visible anteriorly where it inserts into the clavicle. And finally, the deltoid, the rounded, fleshy, soft tissue bulk forming the curved contour of the upper arm. It's the prime site for intramuscular injections.
Moving to the front of the chest, 2 major surface systems come into view. The sternal line is a mostly invisible but easily palpable vertical line running exactly through the midline of the sternum, sitting between the breasts. It's crucial for symmetrical orientation during cardiac and pulmonary examination. Any deviation alerts the clinician to potential asymmetry. On either side of this midline sit the breasts, prominent accessory reproductive organs unique to females, composed of glandular tissue, adipose, and supporting ligaments. Within each breast, 3 structures matter clinically. The areola, a circular, pigmented area of skin surrounding the center of the breast, is examined for color change or texture irregularities. The nipple, a cylindrical prominence with fissures through which lactiferous glands terminate to produce milk, is assessed for discharge, retraction, or lesions. These structures are central to breast cancer screening and lactation assessment in clinical practice.
Now let's move to one of the most clinically important hotspots on the entire body, the cubital fossa. Located on the anterior surface of the elbow, it's a triangular-shaped depression at the junction between the upper arm and forearm. Inside this small triangular space lie 4 critical components. The brachial artery, your primary target during blood pressure measurement with a sphygmomanometer. The median nerve, responsible for fine motor control of the hand. The radial nerve, supplying the posterior forearm and dorsum of the hand. And the biceps brachii tendon, the thick cord you can feel when you flex your elbow. Clinically, the cubital fossa is your go-to site for venipuncture, drawing blood or inserting an IV line, because the superficial veins here are accessible and stable. The stethoscope diaphragm is also placed precisely here to auscultate the brachial artery pulse during blood pressure recording.
The abdomen and pelvis contain some of the most important surface landmarks in clinical medicine. Starting superiorly, the umbilicus, the navel, is a scar marking the former attachment site of the fetal umbilical cord. It has no underlying bone or muscle, but it's a precise midline marker used to divide the abdomen into quadrants for organ mapping. Moving laterally, the anterior superior iliac spine, or ASIS, is a bony projection easily felt on either side of the pelvis, just inside and below the waistline. It's a vital structural coordinate used during pelvic examination, leg length measurement, and surgical planning. Descend to the midline inferiorly, and you reach the mons pubis, a rounded mass of fatty soft tissue sitting directly over the pubic symphysis. It protects the pubic bone and serves as an important landmark in gynecological examination and reproductive assessment. These three structures together give clinicians a reliable pelvic navigation framework.
The lower limb contains two remarkable bony structures worth examining in detail. At the knee, the patella, commonly known as the kneecap, is the largest sesamoid bone in the human body. A sesamoid bone is one that develops inside a tendon, and in this case, the patella sits embedded within the quadriceps tendon, acting as a rigid structural shield in front of the knee joint to protect it from direct mechanical damage. It also improves the mechanical advantage of the quadriceps muscle during knee extension. At the ankle, two bony protrusions define the joint's architecture. The medial malleolus is formed by the inferior end of the tibia and projects on the inner side. The lateral malleolus is formed by the inferior end of the fibula and projects on the outer side. Together, these form the bony pillars of the ankle mortise, gripping the talus and stabilizing the entire joint. These landmarks are critical in assessing ankle fractures and sprains.
Turning to the back, the scapula, or shoulder blade, is a highly dynamic bony structure whose visibility and palpability depend heavily on both body composition and posture. The most consistent landmark here is the inferior angle of the scapula, the lowest point of the shoulder blade, roughly at the level of the 7th thoracic vertebra. On a lean individual, this point becomes dramatically visible during active retraction of the shoulders. When someone pulls their shoulder blades together, the inferior angle projects sharply against the skin and is easily discernible as a bony ridge. In relaxed posture, it lies more flush against the ribcage. This concept, called postural prominence, is important clinically because abnormal winging of the scapula, where the inferior angle protrudes excessively at rest, may indicate weakness or paralysis of the serratus anterior muscle, a condition known as scapular winging.
Here's a concept that surprises many students. The anatomy of the gluteal region contains a common misconception that we need to correct. The gluteal region features two key surface markings. The intergluteal cleft is the central groove running between the two buttocks, created by the outward protrusion of the underlying gluteus maximus muscles. This is straightforward. But the gluteal sulcus, the deep horizontal crease located inferior to each buttock, is frequently misunderstood. The illusion? Most people assume the gluteal sulcus directly marks the inferior border of the gluteus maximus muscle. The reality? The sulcus is actually formed by a deep fold of skin and underlying fascia, and it sits independently of the muscle boundary beneath. The actual inferior border of the gluteus maximus is located superior to the sulcus. This distinction matters clinically during gluteal intramuscular injections and surgical approaches to the posterior thigh, where incorrect mapping could risk injury to the underlying sciatic nerve.
Just as the cubital fossa serves as the neurovascular hub of the upper limb, the popliteal fossa serves the same role for the lower limb, but posteriorly. Located at the back of the knee, the popliteal fossa is a diamond-shaped surface depression, bordered by the hamstring muscles superiorly and the two heads of the gastrocnemius muscle inferiorly. Within this diamond-shaped space lie several critical structures. The popliteal artery and popliteal vein pass deep through the joint space. These are massive vascular conduits that supply the entire lower leg and foot. The sciatic nerve, the largest nerve in the body, enters the fossa from above and bifurcates at its superior border into two branches: the tibial nerve, which continues down the posterior leg, and the common popliteal nerve, which curves around the fibular head to supply the anterior and lateral compartments. Clinically, the popliteal fossa is used for deep pulse palpation and vascular assessment of the lower limb.
At the base of the posterior lower limb sits one of the most mechanically impressive structures in the human body, the heel complex. The calcaneus, or heel bone, is the largest bone in the foot. Its massive posterior protrusion creates a highly prominent surface landmark that you can easily feel when you grip the heel. This bony prominence is the attachment site of the Achilles tendon, the thickest and strongest tendon in the body, which transmits the force of the calf muscles downward to elevate the heel during walking and running. The functional integration of these two structures is remarkable. When body weight bears down through the ankle, the calcaneus absorbs the compressive load and redirects force forward through the foot, while the Achilles tendon provides the counterbalancing pull from behind. This bone tendon anchor point is critical for weight bearing, force redirection, and full body stability during upright posture. Rupture of the Achilles tendon is a serious clinical emergency.
Let's now directly compare the two most important neurovascular hotspots covered in this atlas, the cubital fossa and the popliteal fossa, side by side. The cubital fossa sits on the anterior upper limb at the elbow with a triangular shape. It houses the brachial artery, the median and radial nerves, and the biceps brachii tendon. Its primary clinical uses are venipuncture for blood draws and IV access, and auscultation of the brachial artery for blood pressure measurement. The popliteal fossa sits on the posterior lower limb at the knee with a diamond shape. It houses the larger popliteal artery and vein and the sciatic nerve as it divides into the tibial and common popliteal branches. Its primary clinical uses are deep pulse palpation and vascular assessment of the lower extremity. Both fossa follow the same principle, a surface depression overlying a region of concentrated neurovascular anatomy, making them high-value zones for both diagnosis and clinical intervention.
We close with the big picture. Surface anatomy is not merely geography. It provides precise coordinates for physical intervention and structural assessment. As shown in this final clinical dashboard, every region covered in this atlas has direct, actionable clinical application. The suprasternal notch guides midline orientation and airway access. The cubital fossa enables vascular access and auscultation. Bony landmarks throughout the pelvis and lower limb support structural palpation and musculoskeletal assessment. And the calcaneus Achilles complex governs weight-bearing mechanics assessed in orthopedic and physiotherapy settings. The ability to read the surface of the body with clinical precision is what separates a skilled clinician from a novice. It requires no technology, just trained eyes and informed hands. For medical and nursing students, mastering surface anatomy is one of the highest yield investments you can make early in your training. Thank you for watching Studious. Like, subscribe, and check out the next video in this anatomy series.